Victorine, I think you can start.
Yeah, my name is Victorine Chebet, Med 4, and our facilitator today is Professor Were. So I'll start with the definitions. So labor is a sequence of uterine contractions that result in effacement and dilatation of the cervix, leading to the expulsion of the vagina of the products of conception. That's what labor is. Then induction of labor, it's an intervention designed to artificially initiate uterine contractions, leading to progressive dilatation and effacement of the cervix and vaginal delivery of the products of conception. So induction of labor should be performed after the assessment of the mother and fetus and after indications have been explained to the patient. Augmentation of labor is the artificial stimulation of labor that has already begun that aims to increase the frequency, intensity, and duration of the uterine contractions. Yeah. Then cervical ripening. It's the thinning, softening, relaxation, and opening of the cervix prior to and in response to uterine contractions, which can occur spontaneously or be started iatrogenically. So our objective in cervical ripening is to prepare the cervix for vaginal delivery. That's to improve inducibility of the cervix. So whether or not the patient needs cervical ripening should be determined using the Bishop score we'll see in the next slide. So if Bishop score is less than 5, the patient will need cervical ripening to start, before during the induction of labor, that is. So this is the Bishop score. We have 5 parameters. That's dilatation of the cervix in centimeters, cervical length, the consistency, position, and the station, which is the head station in relation to the pelvis. On dilatation of the cervix, if the cervix is closed, we score 0. If it's 1 to 2 centimeters dilated, we score 1. If it's 3 to 4, we score 2. And if the dilatation of the cervix is more than 5 centimeters, we score 3. On cervical length, if the length of the cervix is 3 to 4 centimeters, we score 0. If it's 2 centimeters, we score 1. If it's 1 to 2 centimeters, we score 2. And if the cervical length is 1 centimeter, we score 3. On consistency, the cervix can be either firm, medium, or soft. So if it's firm, we score 0, medium 1, and soft, we score 2. Then the position of the cervix, this is in relation to the maternal spine. So if the position of the cervix is posterior, that's 0. If it's midline, it's 1. And if it's anterior, we score 2. Then the head station. So our point of reference is station 0, which is the level of the ischial spines. So if the head is 3 centimeters above the ischial spine, we score 0. If it's 2 or 1 centimeter above the ischial spine, we score 1. And if it's at the level of ischial spines, we score 0. If it's below the ischial spines by either 1 or 2 centimeters, we score 3. So indications of cervical ripening. When the Bishop score is poor, that's less than 5, we indicate cervical ripening, and when there are no contraindications to vaginal delivery. Then contraindications of cervical ripening are 1, all contraindications to induction of labor, ruptured membranes, regular contractions, and presence of chorioamnionitis. Complications of cervical ripening, we can have infection and failure to ripen the cervix in preparation for labor.
Did we lose you or what?
Yes?
I I didn't hear things after indication. I don't know if it's only me. Okay, go ahead. I didn't hear you.
Pharmacologic, we have two ways of ripening the cervix. We have the pharmacologic and the mechanical. Pharmacologic, we have prostaglandins, use of prostaglandins and the use of oxytocin. Prostaglandins, we can use misoprostol, which is a prostaglandin E1. We administer 25 micrograms 4 to 6 hourly vaginally, but we can also administer orally. We have dinoproston, prostaglandin E2. We administer by two ways. We can give 3 milligrams in 2.5 mils of viscous gel of colloidal silicon dioxide, 6 to 8 hourly intracervically, or by inserting in the posterior fornix. Or we can give 3 milligrams pessary in the posterior fornix. That's at an interval of 6 to 8 hours. Then we have dinoprost, which is prostaglandin F2 alpha, which we administer intraamniotic or through IV infusion. Then another pharmacologic way of ripening the cervix is by use of oxytocin. The mechanical cervical ripening, we have hygroscopic dilators, which can be natural or synthetic. The natural one, we have a derivative of laminaria plants, and how they work, it's a small rod, which is a small rod of dehydrated seaweed that is inserted in the cervix. So while in the cervix, it rehydrates, absorbing the water from the surrounding tissue. So as it expands, it enlarges the cervical opening. And when it's removed, it creates an easier access to the uterus. We have synthetic, we have the Lamisel and the Dilapan. The Lamisel, this is an osmotic dilator, which is loaded with magnesium sulfate and compressed into a rod. So it works by extracting fluid from the cervical tissue and softening the cervix. Dilapan, it's a slim rod that's made of synthetic palm gel, and they're usually like 3 to 5 rods that are inserted gently into the cervix. Then it absorbs the fluid in the surrounding tissues. So as they absorb the fluid, they expand, stretching the cervix. Then we have balloon catheter, which is 25 to 50 mils balloon, which is passed into the endocervix above the internal os using a tissue forceps. It works by stretching the cervix and by promoting the release of endogenous prostaglandins. Then we have sweeping of membranes, where you use your index finger, you insert in your index finger in the extraamniotic space and rub it. So as you rub it, it stimulates the release of prostaglandins, which cause contractions. And then finally is the nipple stimulation, which works the same way as sweeping of membranes by increasing release of endogenous prostaglandins. So our objectives in inducting the labor is 1, to initiate labor and to achieve vaginal delivery. So we have indications for induction of labor. They're divided into maternal and fetal indications. For maternal indications, we indicate induction of labor in preeclampsia and eclampsia, chronic hypertension, diabetes mellitus, heart disease, chronic renal disease, intrauterine fetal death, acute hydramnios with severe maternal distress, and in abruption placenta. And fetal indications for induction of labor include the following. We have postdatism, rhesus incompatibility, fetal abnormality, chorioamnionitis, premature rupture of membranes, that is, placental insufficiency, suspected intrauterine growth restriction, previous history of intrauterine fetal death, diabetes mellitus, unstable lie after correcting into longitudinal lie, congenital malformations, and abruptio placenta. Then we have contraindications of induction of labor. We have the absolute contraindications and the relative ones. For absolute, we have contracted pelvis, placenta previa, cephalopelvic disproportion, uterine scar due to previous classical CS or inverted T uterine insertion. We have myomectomy entering the myometrium. We have hysterotomy or unification surgery, transverse lie, and pelvic tumor. Those are absolute contraindications to induction of labor. Then we have the relative contraindications, which include breech presentation, oligohydramnios, multiple gestation, brand multiparity, previous cesarean section with transverse scar, prematurity, and heart disease. So induction methods, the methods we use to induce labor, we have the medical and the surgical methods of induction of labor. The medical ones, we use oxytocin. We will see in the next slide that we administer the oxytocin, and we have prostaglandins. We have the surgical or mechanical methods, which include amniotomy or artificial rupture of membranes. So in the artificial rupture of membranes, for the lower rupture of membranes, we use the amnihooks or Kocher's artery forceps, and it should initiate labor in like 0.5 to 1 hour. If not, we supplement with oxytocin. Then the high rupture of membranes, we use the Drew-Smith catheter, but it's obsolete, no longer being used. Then we have the sweeping of membranes that I had explained earlier. So on the administration of oxytocin for induction of labor, we administer 5 international units in 500 mils of 5% normal saline. We start at 4 drops per minute and then increase by 4 drops every 30 minutes. So the dose of oxytocin is escalated until 3 contractions in 10 minutes, each lasting 40 seconds are achieved and maintained. Or when contractions are adequate, that's more than 40 seconds each and each lasting 3 to 10 minutes. At 60 minutes, we continue infusing at that same rate. Then start a new bottle. If the contractions are not achieved, we start a new bottle with 10 international units of oxytocin in 500 mils of normal saline and start infusing at 30 drops per minute, then escalate by 4 drops every 30 minutes to a maximum of 40 drops per minute. In case of hyperstimulation, we administer salbutamol 5 milligrams in 5% dextrose at 10 drops per minute until reassuring uterine contractions are achieved. Now, patient monitoring during induction of labor. So during induction of labor, we should start a pathograph once the patient is in active labor or once the patient has been administered with oxytocin. Then blood pressure is taken at least every 4 hours and every 1 hour in preeclamptic patient or eclamptic patients. We record pulse every 30 minutes. Then abdominal palpitation to palpations, not palpitations, sorry for that. Abdominal palpation to assess contractions for 10 minutes every 30 minutes. Then we assess the cervical dilatation at least every 4 hours or more frequently if indicated. Then assessment of fetal heart rate every 30 minutes. So as you take the pulse of the mother, you check for the fetal heart rate every 30 minutes, listening after a contraction or at least 1 minute after the contraction, sorry. Then we assess the color of the liquor, if there is presence of meconium or blood in it. This is a flow chart that it's a protocol for induction of labor. You'll check that at your own time. So on to complications of induction of labor, we have the maternal and the fetal complications. Maternal complications, we can have failed induction. and hyperstimulation. Hyperstimulation can result in fetal distress, uterine rupture, or amniotic fluid embolism. The mother can also have fear and anxiety during induction of labor, and it can result in infection. Fetal complications, we have iatrogenic prematurity, hypoxia, physical injury, cord prolapse, and infection as well. And finally, the complications of amniotomy, which is artificial rupture of membranes. We can have amniotic fluid embolism, cord prolapse, abruption of placenta, amnionitis, and accidental injury to the cord, cervix, uterus, or fetal parts. That marks the end of my presentation. So any questions before Prof takes over?
I have a question. When you are presenting about the contraindications for you're talking about cervical ripening, you said that patients with chorioamnionitis cannot undergo cervical ripening, and I wanted to know what is the indication or what is the reason why they can't undergo cervical ripening, yet they can undergo induction of labor. Is my question clear?
Pardon, please.
I was asking, what is the reason why patients with chorioamnionitis cannot undergo cervical ripening, yet they can undergo induction of labor?
Anyone with a definite answer can give us the answers, I confirm.
The reason for cervical ripening was for induction of labor. So I think once you have achieved cervical ripening, that is by increasing your Bishop's score, then you can induce them. By that I mean they can undergo both induction and so after cervical ripening, they can be induced for delivery because I think it is encouraged that they deliver vaginally, and if they do not have contractions, then we have to induce them for us to achieve vaginal delivery. Thank you.
Okay, so any additional questions for her? Someone is asking, Nicholas Kyoko is asking, do we include station as part of Bishop's score? It's a good one. Victorine, are you going to do that?
As per our protocol, the head station is not part of the Bishop's score. So I think we can omit.
Okay. There is another question. What is the limit of Bishop's score for induction of labor from Ben? I guess what is the lowest Bishop's score that is compatible with induction of labor?
I think lowest should be 5. The lowest, that is.
Okay, so she has answered. Any additional questions? If not, then we can highlight a few issues here for general consumption. Thank you very much, Victorine, for a nice and brief presentation. Possibly gives us time for discussion. I think I want to generally that the key elements of the presentation brings out the issues that you should know about in terms of induction of labor. But just to reiterate, induction of labor is easily one of the most common procedures that we do in obstetrics after things like cesarean section and normal delivery. And therefore, it's a subject that you should be familiar with and basically be able to highlight the key elements of it. It is a required knowledge because it's a procedure that is very common. It has potential for benefit, but it has also potential for increasing the risk of bad or poor outcomes. And so familiarity and having the skills around it is required knowledge, both at 4th year and even at 6th year. So my comments are going to revolve around the physiological basis of induction of labor. I'll revisit briefly something about Bishop's score, which is what I believe it was Kyoko was asking. Then we'll talk about a few other areas that require clarification from Victorine's presentation. So the physiological basis of normal onset of labor. If you look at the cervix and the way it behaves outside pregnancy and within pregnancy is an extremely interesting or intriguing structure, because in early pregnancy, you want the cervix to have the capacity to hold on to a pregnancy, to allow a pregnancy to occur, then hold on to that pregnancy until that pregnancy reaches term. And at term, it should then switch its roles to allow the delivery of the, of the fetus or of the baby. And those roles are actually the exact opposites of each other. So how does this happen? I think that is important physiological basis that people need to be aware of. So in normal circumstances, anatomically and histologically, the cervix consists of, the uterus consists of the uterine fundus, which is largely myometrial and almost 95% myometrial, very little fibrous tissue, as opposed to the cervix, which is almost about 35% muscle and 60% or 65% fibrous tissue. And so if you look at the function of the uterus and the cervix, then the uterus usually is a contractile organ, and that's the function of the myometrium. And secondly, the cervix is usually a structure that is supposed to, particularly in early pregnancy, to hold on to that pregnancy. So how does it do that? You know that if the cervix is weak, then you end up with things like recurrent abortions, and then we have to put sacrilege. So in normal circumstances, in early pregnancy, there are very low levels of oxytocin receptors, which are usually a factor also of the estrogen receptors, but mostly the oxytocin receptors increase in numbers as you get towards term. So at the beginning, they are relatively few, and towards the end, if you like, at term, then the number of oxytocin receptors are increased substantially. That is one aspect of the physiology of the cervix as related to pregnancy. So therefore, in early pregnancy, the cervix is less likely, the uterus is unlikely or less likely to contract to try to expel the contents, or if you like, the products of conception. And the cervix, being mostly fibrous, hangs on to that pregnancy. So that way there's retention of early pregnancy until towards term. But there's another element which is at the biochemical and physiological level, which is the composition of the ground substance and its relationship to the affinity to the collagen fibers that are there in the cervix. And this is what makes the cervix as good as it is in early pregnancy in holding onto the pregnancy, but later on it changes. So in early pregnancy, you find that if you look at the structure of the cervical fibrous tissue, it consists of a ground substance, and it also, within that ground substance, you have the collagen fibers. So if the ground substance has high affinity for collagen fibers, then there's a tendency for the cervix to remain closed because there's no room for stretching, because the ground substance is holding so tightly to the collagen fibers. So what happens is that it has been, biochemists have found that in early pregnancy, the collagen, the ground substance that you find in the fibrous tissue of the cervix has very high affinity for collagen, and therefore it holds onto it. It doesn't allow it to move. But as you move towards term, there's a change in the ground substance under the influence of both estrogen and progesterone, and this leads to a change towards lesser and lesser affinity for collagen. There are specific names which I don't want to go into in terms of the biochemistry of fibrous tissue. But the bottom line is that towards term, there is less affinity for collagen in that ground substance. Think of this as, I don't know, all of you will have seen a koroga, or the way the masons develop the pillars. So you have iron bars inside, and on top of that iron bar, you then pour concrete. So, and think of that collagen fiber as the iron bars and the concrete as the ground substance. So if you have very strong cement, like the power plus they use for making bridges, it holds on to the iron bars very firmly. So immediately you pour that so-called koroga, you can't pull out those iron things. But if you have the low-level cements like the rhinos and the buris, then you can pull it out. That's the concept I'm trying to get across. So in early pregnancy, it is like you have that very tightly holding ground substance. And so the cervix does not distend easily. The other important aspect is the amount of water or hydration of the cervix. As people go towards term, the cervix absorbs more and more moisture, and the amount of moisture within that ground substance increases. And so early pregnancy, little moisture, very high affinity for collagen. Towards term, there is excessive moisture. The cervix is very soft. That's why it becomes soft, by the way. And there is low affinity for the collagen fibers. And therefore, the cervix is more likely to open up. And even as that happens, the uterine muscle has acquired more oxytocin receptors and therefore is more contractile. So at some point, there gets to be so many uterine contractions, the so-called Braxton-Hicks contractions, merge into substantial contractions, which then happens at the fundus, and the cervix being more extensile because of high hydration and low affinity for collagen in the ground substance opens up easier. So that's the biological, or if you like, the biochemical and physiological basis of the normal onset of labor. So the other thing that I wanted to clarify is that, so you expect, therefore, that as you get closer to term and near the beginning of a delivery, that the so-called cervical inducibility score will improve. The cervix will become softer because there's more water and it is more malleable, it is more extensile. It will become shorter, it will become more open, and the position generally faces anteriorly. And that is all the clinical effects of these changes in the ground substance. So that is the first point. So in terms of Bishop's score, Kyoko asked whether the station is important or not. We have the original so-called Bishop's score, which had a station included as part of the things that are being assessed. But in current work, what we have, or what we use even in MTRH, is the so-called modified Bishop's score. And in the modified Bishop's score, station has been removed. And it's important to understand why station has been removed. And the reason is simple, that it has been observed that the women in most women of negroid extraction tend to have a smaller gynecoid pelvis. And so generally there is very little chance that they will have what is called fetal presenting part engagement. And when I say engagement here, this is in the correct obstetric use of that word. So there's very little chance of fetal head engagement by 36 weeks. If you go to the other, especially women with the Caucasian extraction, and even Indian, because the Indians have a small gynecoid pelvis, but their babies tend to be smaller in body size and compared to the African ones. But among the Caucasians, they tend to have large pelvis, and that large pelvis translates into potential for engagement early. And so that is why they had station, because Bishop was doing this work in a Caucasian population. So if you included the station, then you would continually score it 0, because majority of our women, before they go into labor, will not have the head engaged. And that is why it was removed, because it was not adding any value. And besides, we are not assessing station anymore. We assess descent. Descent is an abdominal examination, while station is a vaginal examination that requires a lot of anatomical orientation within that pelvis, using just your fingers. It's like working in a cave blindfolded and just using the feeling of touch and finding your way. So the inaccuracies around that and the fact that it wasn't adding any value is why it was removed from the scoring system. So now we have the modified Bishop score. So that is what we have, and which anything score 6 and above is considered to be inducible. So I think I've clarified that. The other important thing to note is, before you decide to do an induction of labor, there are usually 2 processes that meld into each other. That is, there's the issue of ripening followed by induction. And because ripening uses the same approaches or similar approaches to induction of labor, though not exactly, we know we use misoprostol for both, and we can actually use even catheters or dilators for induction as well, if you put them there long enough. because of that, there's a confusion usually in the minds of people who do not keep their mind on what the objective is. And it is critical that you know what you are trying to achieve with whatever process. So if it is ripening of the cervix, then the outcome measure for ripening is an improved cervical inducibility score. So in other words, if it was less than 5, and now you are at 7 or 8, then your objective has been achieved. And it is not that if you are ripening the cervix, you expect that there will be delivery, because delivery is an objective for induction. And I'm saying this and stressing it because it is extremely important, because a lot of patients get, especially in the early days with little postgraduate work going on here, there was a lot of confusion among the medical officers we were working with about when to decide that there has been a failure of ripening. So someone would start doing ripening of the cervix, but they imagine that their outcome measure is whether there is established labor and delivery. And obviously when that failed, then the next step is a cesarean section. So it means, therefore, if you mix your objectives, then you are going to do unnecessary cesarean sections with all its complications and consequences for subsequent pregnancy. So you have to be extremely clear in your mind, what are you doing? Are you trying to ripen the cervix, in which case the improvement towards a better score is what your objective is and your outcome measure. But if you are doing an induction, then the outcome is delivery. And those two things are different. You have to keep your mind wrapped around that. Okay, so there are other areas to clarify in terms of the choice of what methods you use, and particularly in misoprostol and dinoprost. You talked about dinoprost, which is prostaglandin E2, as opposed to misoprostol, which is an analog of prostaglandin I. Okay. So the reason misoprostol has become very useful is that it is a stable molecule and it can be stored at room temperature. You don't have to worry about its stability, and the stability is good whether you are in Turkana or you are in MTRH or in Nairobi. The stability is good and there are no special storage requirements. The cost is also very manageable. As you may know, one tablet of misoprostol, about 200 micrograms, is usually less than 150 shillings. As opposed to dinoprost, which is a very expensive thing, requires refrigeration, and its stability is suspect in our weather. So misoprostol is a no-brainer. It is the choice when you are thinking about using prostaglandin-based approaches towards ripening. The other important thing to note is that there are controversies around what amount of misoprostol should be used. The obstetric indication for misoprostol is usually starting with 25 micrograms. Although, because of challenges in obtaining the obstetric formulation, people have used the general formulation, which is 200 micrograms, and broke it down to 50-50, a quarter. And that is double the dose. So you have to keep your mind around that fact that for obstetric purposes, the initial dosing should be 25 micrograms. But if you are using the tablet and breaking it down, then you are ending up with a minimum of 50 micrograms, which is double the dose. And therefore you have to be extremely careful about the potential adverse experiences. So those are cautions you need, practice cautions. Then there is the use of Foley's catheter, which is something that we have also used to dilate the cervix and to also release endogenous prostaglandins, either in ripening or even sometimes in induction. Follis catheter works, but again, there are controversies around whether we should use 25 to 50 mils of normal saline, or whether we should use higher doses, or rather higher amounts to blow up that, the balloon, because there is suspicion that, or there is evidence that the bigger the balloon, the more effective it is in terms of generating rather releasing the endogenous prostaglandins. There was a point that I want to clarify, which Victorine mentioned, that nipple stimulation leads to release of endogenous prostaglandin. It doesn't. What nipple stimulation does is to work through the ejection reflex, which starts with milk ejection reflex, which starts at the nipples and is wired to the posterior pituitary, and that is where the oxytocin is released. And the original or the real reason for it is for milk ejection, but because oxytocin is released through stimulation of the nipples, that oxytocin will also have impact on the uterus or all the other smooth muscles that have oxytocin receptors. And obviously, as the cervix generates and the uterus generates more oxytocin receptors, nipple stimulation can actually lead to contraction of the uterus and lead to the taking up of the cervix and ripening of the cervix. It's not through endogenous prostaglandin. Lastly, I want to say something briefly about the timing of induction of labor. The timing of induction of labor is extremely important depending on which condition you are that is indicating induction of labor. Ideally, induction of labor should be done at 39 weeks, or if you like, 38 completed weeks. Because the worst thing that you can do is to take out a preterm baby and then have to take the baby to nursery, unless the indications are that are on fetal interest, if you see what I mean. And therefore, either you wait to 39 weeks, or if it is on maternal interest, or do fetal lung maturity tests to be sure that the fetus is mature before you do induction of labor. And lastly, I want to make a comment on other indications of induction of labor. Induction of labor, the indications that were put here were quite correct, but now there are also social indications. The social indications can include things like somebody who feels that they want to have their baby out or the pregnancy terminated at term, of course, but because they have other things they want to do. And a common one is people going for a wedding, and they don't want to go there with the baby there doing all those cakes and so on. So they want the tummy trim and looking good. So that is not an indication for induction of labor. The other possible, common reason is economical, especially in private practice, where a doctor with multiple patients they are looking after wants to go or travel, and because they don't want the patients to deliver during their absence, sets on a course of doing multiple inductions of patients. The reason this must be discouraged is that in any of those circumstances, whether it is the patient-derived induction because they want to look trim, or because the doctor wants to go on holiday or go on a conference, those are not indications, because once you decide to induce a patient, and if Victorine can show the methods, because she had it. Victorine, can you track back to where you had the methods of induction, please? Yes, the methods there, no, back, yeah, there. So the methods of induction are either medical or surgical. And among the medical, the most effective is oxytocin use, and has been described in the next slide. But generally, there's also amniotomy that is done. So when you do amniotomy, you release endogenous prostaglandins, and then when you put up oxytocin, or even if you don't, there will be contractions, and then the induction will proceed, labor will proceed, and delivery will happen. So if it does fail, then the obvious next thing to do is, and you have done your amniotomy, you have put up your oxytocin, and then labor does not begin. The only recourse is cesarean section. And therefore, if there's a possibility that because of your intervention, somebody is likely going to end up with a C-section, that indication must be a clinical indication and not a social indication. It cannot be driven by you going away as a practitioner and now you want to deliver everybody who is at term. That cannot be an indication, because the consequences of failure are too grave to, to think about on anybody. So those are some of the things I wanted to highlight and to emphasize, and I think I want to leave it at this point and maybe tackle if there are any leftover questions. I think Victorine had answered all of them. It seems somebody's written something in the chat. Why is Buscopan sometimes used to ripen the cervix? Buscopan is not really used to ripen the cervix. It's never been used for that. Buscopan is thought to be helpful in, reducing, it is what? It is an antispasmodic. It relaxes smooth muscles. So it has been shown that in some doses, given particularly parenterally, intravenously, it helps in relaxing the uterus. And when the uterus is relaxed, the patient's labor proceeds better, but it's only when the patient is already in labor and going on and the contractions are such that they feel very uncomfortable. The mechanism by which it relaxes the system so that dilatation happens better is not quite obvious. But yes, it has been used to relax the patient and relax the cervix so that dilatation happens easier during labor, not without labor. You can't start off by giving Buscopan hoping to ripen the cervix. But when the patient is in labor and you give Buscopan, particularly intravenously, then the observations are that the cervix opens up much faster. And I don't think that is equated to ripening. Next. Any additional questions? You can either say it directly through the host or write it.
I'm Flavian. So
Yes.
you say that the amount of normal saline we use for the Foley catheter is between?
Currently we use, depending on which catheter you use, usually about 40 to 50 or thereabout. But what I'm saying is that there is what you can call equipoise. We don't know for sure, but there are studies that have suggested that if you used a higher amount of normal saline in that balloon, because the way it is done is you insert the catheter into the cervix and then blow it so that it becomes a self-retaining catheter. And then you pull it down onto the internal os and anchor it on the thighs of the patient. So it is suggested, there is evidence to suggest that If you used a higher volume of normal saline and you pull it like that, then you get a much better effect. The ripening is faster, and by the time the catheter is being expelled, the cervix is much more dilated, and you probably get better results in terms of procession into active labor. I know of a student within a resident who is working on that, comparing the two, 50 mils and 80 mils. Otherwise, the whole thing is about catheter, but one is blown by 50 mils, another is blown by 80 mils. To see which one of those reaches an inducible cervix faster. Yeah, the appropriate Bishop's score is anything above 6. Next. Okay, so it seems we are at the 7 minutes to the hour that we were supposed to use. And so I guess since there are no additional questions, we can call it a day. Host?
Okay, thank you, Prof, for the facilitation, and thank you, Victorine, for the presentation, and the others for attending.
Thank you.
Okay, have a nice evening, Prof.
Have a good time.